Welcome. In this session, we will be discussing perimetry or visual field analysis in glaucoma. We will be discussing automated perimetry in detail and briefly discuss about manual kinetic perimetry. And we will discuss the testing algorithms, testing strategies and test reports of Humphrey visual field analyzer among the automated perimeters. The normal visual field extends 60 degrees superior to fixation up to the forehead, 60 degrees nasal to fixation up to the bridge of the nose, 70 degrees inferior to fixation and 110 degrees temporal to fixation. The hill of vision is the plane joining the visual sensitivity levels at various locations in the visual field. In profile, the hill of vision peaks sharply at the fovea, then has a more gradual decline in the form of a plateau and finally declines sharply again in the periphery. The blind spot is an area 10 to 15 degrees temporal to fixation in the visual field, and it corresponds to the optic nerve head located 10 to 15 degrees nasal to fovea where photoreceptors are absent. This diagram shows visual field of the left eye and visual field of the right eye. When examining a visual field test report, we orient the report in such a way as if the visual field test report belongs to our own eye. In the left visual field, we will find the blind spot located to the left and temporal to fixation, and in the right visual field, we will find the blind spot located to the right and again temporal to fixation. And in the nasal to temporal profile of the hill of vision, the blind spot will appear as a discontinuity in the hill located temporal to the fovea. The blind spot has two zones, a zone of absolute scotoma represented in black in this diagram and a zone of relative scotoma represented in gray in this diagram. In the zone of absolute scotoma, even light of maximal intensity is not seen, and the zone of absolute scotoma corresponds to the optic nerve head and is vertically oval in shape. In the zone of relative scotoma, light of higher intensity is perceived, and the zone of relative scotoma corresponds to the peripapillary retina, particularly at the superior and inferior poles of the optic nerve head where the retinal nerve fiber layer is thickest, thus obscuring the photoreceptors located more posteriorly in this region. Perimetry enables functional assessment of a glaucoma patient by detecting visual field defects. Peripheral visual field is lost early and central visual field is lost late in glaucoma, and this is very important to remember. Perimetry evaluates the visual field by assessing the ability of a subject to detect a stimulus on a uniformly illuminated background. Automated perimetry, or more specifically automated static threshold perimetry, evaluates the threshold sensitivity at predetermined locations in the visual field. Threshold sensitivity at a particular test location is the minimum brightness of the stimulus which the subject can detect 50% of the times the stimulus of that intensity is presented at that test location. And this is done by presenting stationary stimulus at these predetermined test locations in the visual field. The machine then compares the threshold sensitivity measured at each test location with normative data already present in the machine. The normative data refers to the threshold sensitivity measurements in a large number of normal individuals, and this normative data is age bracketed. That means when a subject undergoes automated perimetry testing, his or her threshold sensitivities at each test location is compared with the threshold sensitivity data of normal individuals in a comparable age group. Standard automated perimetry, in which a white light stimulus is shown on a white background, and so-called white-on-white perimetry, is currently the gold standard of perimetry. Standard automated perimetry enables us to detect and quantitate visual field defects and detect progression as well as the rate of progression of visual field defects longitudinally over time. This photograph shows the Humphrey visual field analyzer, the most widely used automated perimeter. This photograph is that of another perimeter showing the forehead rest and the chin rest for the patient, the lens holder in which The lens correcting the refractive error of the patient is positioned in front of the patient's eye, and we can see the ball behind, which is white in color, having a central fixation light on which the patient needs to fix it throughout the test, and several dots in the periphery representing the various test locations in which the stimulus is presented. The background illumination is 31.5 apostaves being unit of luminance, and this amount of illumination saturates the rod photoreceptors so that only the cone photoreceptors are responsive. Size of the stimulus can vary from 0.25 square millimeters to 64 square millimeters, and the size 3 stimulus, which is 4 square millimeter in area, is routinely used. Size 5 stimulus can be used in patients with poor vision. Intensity or brightness of the stimulus can vary from 10,000 apostaves to 0.1 apostaves, and the exposure time of stimulus is 0.2 seconds on the Humphrey visual field analyzer. Manual kinetic perimetry, as shown here in this photograph, differs from automated static perimetry. In automated static perimetry, a stationary stimulus is presented, but in manual kinetic perimetry, the stimulus is moved from a non-seeing area towards a seeing area along specific meridians. So along every meridian, the stimulus is moved from a non-seeing area to the seeing area, and the point at which the moving stimulus is first seen is marked along every meridian, giving isopters specific for a particular stimulus. So this is an isopter for a specific stimulus, and the characteristic of the stimulus is given here in the key, and similarly these isopters are generated by different specific stimuli whose characteristics are also given in the key. And isopters can be obtained both at the periphery by moving from a peripheral non-seeing to a central seeing area, and also at the center, such as for determining the blind spot by moving from a central non-seeing area towards the peripheral seeing area. The stimulus is moved along each meridian by this lever, and the patient's fixation is monitored with this telescope. As compared to manual kinetic perimetry, standard automated perimetry is faster, allows random presentation of stimuli at various locations, is more sensitive in detecting early defects, is less operator dependent, and allows statistical analysis of defects to diagnose their significance and determine whether they are progressing or not, and also allows us to determine the reliability of the report itself. However, manual kinetic perimetry may still be required for patients not able to perform standard automated perimetry. Thresholding is a very important concept in perimetry, and automated perimetry determines the threshold sensitivity at designated locations in the visual field. Threshold sensitivity of a particular location in the visual field is the minimal intensity of the stimulus which the subject can detect 50% of the times the stimulus is presented at that location. Precise thresholding at each test location is not clinically feasible because of the length of time it will take. So in clinical perimetry, thresholding is done up to a precision level of 2 decibels. We'll come to decibels soon. In this diagram, this line represents the threshold sensitivity at a particular location in the subject's visual field, and these lines represent the change in the intensity of the stimulus presented at that particular location. So if the patient sees the initial stimulus, the intensity of the stimulus is decreased stepwise till the patient does not see the stimulus, and then the change in intensity is reversed, usually in steps half those of the previous steps, till the patient sees the stimulus again, and the intensity of this stimulus is recorded as the threshold intensity of this location, and from this threshold intensity the threshold sensitivity of that location is calculated, as we shall see. Similarly, if the subject does not see the initial stimulus, the intensity of the initial stimulus is increased stepwise till the patient sees the stimulus, and then the change in intensity of the stimulus is reversed till the patient does not see the stimulus. So the stimulus intensity is recorded as the threshold intensity at this location, and from this threshold intensity the threshold sensitivity is calculated, as we shall see. Usually, the initial steps by which the stimulus intensity is changed is 4 decibels, and during the reversal, the intensity is changed by 2 decibels. So the recorded threshold sensitivity has a precision of 2 decibels. So the threshold sensitivity at each testing location is reported in decibels as shown in this numerical threshold sensitivity plot. And the threshold sensitivity in decibels is calculated from the difference between the intensity of the threshold stimulus and the intensity of the maximum stimulus projected by the machine, which is 10,000 aposteps. So the machine measures the intensity of the threshold stimulus at each location in aposteps and reports the threshold sensitivity of that location in decibels in this numerical threshold sensitivity plot. We'll see that there is a logarithmic relationship between the intensity of the threshold stimulus measured at a test location and the threshold sensitivity reported at that location. And also, as the intensity of the threshold stimulus decreases, the reported threshold sensitivity increases. In this diagram, these circles represent 6 intensities of stimulus. Among all the stimulus intensities that can be projected by the machine from the brightest to the darkest, and against each of these 6 selected stimulus intensity, there is a stimulus intensity value in aposteps and a threshold sensitivity value in decibels. The brightness of the 6 stimuli shown here starts from 10,000 aposteps, the maximal stimulus intensity which can be projected by the machine, and decreases tenfold for every successive darker stimulus up to 0.1 aposteps. And the corresponding threshold sensitivity in decibels ranges from 0 decibels to 50 decibels and differs by 10 decibels for each successively darker stimulus shown here. So if at a test location the subject is not able to perceive stimulus intensity of 10,000 aposteps, the threshold sensitivity of that location is reported as 0 decibels. If that test location is able to perceive stimulus intensity of 1000 aposteps or brighter, the threshold sensitivity of that location is reported as 10 decibels. If that test location is able to perceive stimulus intensity of 100 aposteps or brighter, the threshold sensitivity of that location is reported as 20 decibels. If that location is able to perceive stimulus of intensity 10 aposteps or brighter, the threshold sensitivity of that location is reported as 30 decibels. If the testing location can perceive stimulus of intensity 1 apostep or brighter, the threshold sensitivity at that location is reported as 40 decibels. And if the testing location can perceive the darkest stimulus projected by the machine of 0.1 apostep, the threshold sensitivity reported at that location is 50 decibels. So if the subject does not respond to a stimulus of intensity 10,000 aposteps at a particular location, the threshold sensitivity at that location is said to be 0 decibels. And as we have mentioned, every 10 decibel increase in threshold sensitivity corresponds to tenfold reduction in the intensity of the minimum perceivable stimulus from 10,000 aposteps, which is the intensity of the brightest stimulus projected by the machine. In other words, the better the visual function at a test location, the lower the threshold stimulus intensity, and the larger the numerical value of threshold sensitivity in decibels. And this is very important to remember. The threshold sensitivity value in decibels can be reported as any integer value between and including 0 and 50 decibels. So although this diagram shows 6 decibel values can be mentioned as any integer value in between, while maintaining a logarithmic relationship between the measured stimulus intensity and the calculated threshold sensitivity. In the Humphrey Visual Field Analyzer, the test points are located in a grid 6 degrees away from each other, and in the center, the test points are located 3 degrees away from the horizontal meridian, which enhances detection of visual field defects along the horizontal meridian, which, as we shall see, is a particular characteristic of glaucomatous visual field defects. Usually the central 24 or 30 degrees are tested, and these are known as the 24-2 testing strategy or 32 testing strategy on the Humphrey Visual Field Analyzer. This is the 32 testing strategy on the Humphrey Visual Field Analyzer, and an area of the visual field 30 degrees from the central fixation is tested in this testing strategy. And this is the 24-2 testing strategy on the Humphrey Visual Field Analyzer, and an area of visual field 24 degrees from fixation is tested in this strategy. In patients with advanced visual field loss and those with paracentral scotomas, the central 10 degrees can be tested with testing locations 2 degrees away from each other, and this is called the 10-2 testing strategy on the Humphrey Visual Field Analyzer. With a 10-2 strategy in a patient with advanced visual field loss, we get a better definition of scotoma as well as early detection of progression of the scotoma. On the other hand, it has also been seen that patients with early glaucoma often show abnormality in 10-2 testing strategy in the absence of any defect in the 24-2 testing strategy. So this is the 10-2 testing strategy on the Humphrey Visual Field Analyzer, and an area of visual field 10 degrees from fixation is tested in this strategy. Points between 30 degrees and 60 degrees from fixation, although present in the perimeter, are usually not tested because of high variability in threshold sensitivity in these areas. In very advanced glaucoma, detecting progression with 24-2 testing strategy may not be possible, and the following strategies may be helpful in these situations. We may use a 24-2 testing strategy with size 5 stimulus, but criteria for abnormality detection with size 5 stimulus has not been defined. Or we can use the macular test strategy as shown here in this photograph, and in the macular test 16 points in the central 5 degrees as shown in this plot are tested twice. It has been found that 16% of glaucoma suspects have defects in the 10-2 testing strategy in the absence of either defects in the 24-2 testing strategy or defects in the retinal nerve fiber layer on OCT testing. And in these patients, instead of doing two tests, one with the 24-2 strategy and the other with the 10-2 strategy, a single test with the 24-2C strategy available with the Sita Faster algorithm in the Humphrey Visual Field Analyzer can be done, and this testing strategy incorporates 10 test locations of the 10-2 program in a 24-2 testing strategy. This figure shows the test locations of the 24-2C testing strategy, in which, in addition to the standard test locations of the 24-2 strategy, 10 additional test locations, as marked in red in this figure, is taken from the 10-2 testing strategy and are tested together in the same testing session. This photograph shows a test report with the 24-2C testing strategy. Following initial diagnosis of glaucoma, it is recommended that 3 equally spaced visual field testing should be done per year in the initial 2 years so as not to miss patients with fast progression of their visual field defects. Following these initial 2 years, testing frequency can be reduced to 2 fields per year in patients with slow progression. And in any particular patient, to detect progression longitudinally over time, it is important to use the same algorithm, the same testing strategy on the same machine. When performing the test, the patient's name, age and sex is entered in the machine, and the time of testing is entered automatically by the machine. The testing strategy is selected, and the eye being tested, whether the right eye or the left eye, is selected. Refractive error correction of the patient for near is placed on the lens holder, and the patient is asked to place the chin on chin rest, touch the forehead on the forehead rest, and look through the center of the corrective lens. The patient is instructed to keep fixating at the central fixating light, which is red in color, and to press the clicker once and release it when he or she sees a peripheral blinking light which is white in color. The room illumination is dimmed and the test is started. So the central fixating light, which is red in color, is projected from the center of the ball, upon which the patient must fixate throughout the test, and the testing stimuli, which are white in color, are projected from the periphery of the ball. Factors affecting perimetry result include age of the patient, as there is a decrease in threshold sensitivities with increasing age, and this, as we have seen, is corrected by normative data, which is age bracketed. Pupil size less than 2.5 mm causes generalized depression of threshold sensitivities across the visual field. On the other hand, mydriasis can also affect test result. Refractive error should be corrected for near so that the stimulus is seen by the patient. Posterior staphylomas can decrease sensitivity by blurring the image of the stimulus, and these are called refraction scotomas. Media abnormalities such as cataract, corneal opacities, and posterior capsular opacification can affect test result by causing generalized depression of threshold sensitivities across the visual field. But it has been seen that performing applanation tonometry prior to visual field testing does not affect the result of visual field test. Patient's attentiveness and reaction time can also affect result of perimetry, and proper positioning of the patient on the machine is very important, with the eye being tested positioned close to and centered on the correcting lens to avoid a lens rim artifact. Length of the test can affect test results, with longer tests affecting the attentiveness of the patient. And perimetry still plays an important role, although the test is automated. Although the role of perimetrist is much less in automated perimetry as compared to manual kinetic perimetry, it is still there. The perimetrist must instruct the patient how to perform the test by telling him or her where to fixate, where to expect the stimuli, and how the stimuli will look like, to press and immediately release the clicker upon perceiving a stimulus, when to blink, and how long the test is expected to take. It is important to remember that many stimuli will be barely visible to the patient, and approximately half of the stimuli will actually not be perceived by the patient. The perimetrist must also monitor position of the patient and fixation by the patient on the central red fixating light. Before we start to interpret a visual field test result, it is useful to know about the software package present with the machine. StatPack is the trademark software package available with the Humphrey Visual Field Analyzer, and StatPack contains two large databases. StatPack itself contains threshold sensitivities at the test locations in normal individuals, and StatPack 2 contains threshold sensitivities at the test locations in stable glaucoma patients. The software gives printouts, which helps us in detection of visual field defects and in determining progression of these visual field defects. It is important to note the various sectors in a standard printout of a visual field test result. This photograph shows such a standard printout. In this area we get the patient identification details. Here we get the reliability indices. In this area the testing conditions are mentioned, and these four areas show the plots: the numerical, the grayscale, the two total deviation plots, and the two pattern deviation plots. And we have the indices in this sector: the glaucoma hemifield test, the visual field index, and the mean and the pattern standard deviations. At the very bottom of the printout we get the gaze tracker report. One thing to note here is that this visual defect is not typical of glaucoma, as it respects the vertical meridian. We'll be using this test report to describe the structure of a test report and the significance of each of the items in the test report. We'll be discussing the typical glaucomatous visual field defects later. The basic parameters to identify and confirm include identification of the patient and date and time of the test. These two parameters tells us that we are analyzing the correct report. Confirming correct entry of patient's age is very critical because, as we have discussed, the normative data is age bracketed. We should also note the stimulus type used, the background illumination, and the testing algorithm used, which are mentioned in this area of the printout. Reliability indices located in this sector of the test report tells us about the quality of the test. In other words, the machine itself tells us how accurate the test was and how much can we depend on the report. The reliability indices include fixation loss, false positive error and false negative errors. In fixation loss, the patient's fixation moves away from the central red fixation light, and fixation loss can be measured by two methods: the Heil-Krakow method or the blind spot method, which is a catch trial method, and the gaze tracking method. In the Heil-Krakow method, at the very beginning of the test, the physiological blind spot is mapped, and during the test, stimuli are presented periodically in this originally mapped location of the physiological blind spot. If the eye moves during the test, the location of the physiological blind spot will also change, and stimuli presented in the originally mapped location of the physiological blind spot will be seen. On the other hand, a patient maintaining fixation should not be able to perceive the stimuli presented in the originally mapped location of the physiological blind spot. Gaze tracking is the other method of determining fixation loss, in which with an infrared light the machine monitors the position of the pupil of the eye being tested, and the tracking record is given at the bottom of the test report. Upward lines in the gaze tracking report indicate fixation loss, and downward lines, which are not seen here in this gaze tracking report, represent moments when the machine was not able to track due to blinking. And it is recommended that fixation loss of more than 25% should not be accepted, and this is an important figure to remember. A response is said to be false positive when the patient presses on the clicker without perceiving any stimulus. In the current generation of CETA testing algorithms, if the patient responds immediately before, during, or immediately after the presentation of the stimulus, that is within 200 milliseconds of presentation of the stimulus, the response of the patient is considered to be false positive. In the previous generation of full threshold strategies, catch trials with blank presentations were employed to detect false positive response. False positive response is the most detrimental among the reliability criteria to affect the accuracy of the test, and it is recommended that false positive response rate more than 15% should not be accepted, and this is a very important figure to remember. And a false negative response is said to occur when the patient does not respond to maximal intensity stimulus at a testing location where he or she has previously responded in the same testing session, and causes of false negative response can be lack of attention as well as high short-term variability in threshold sensitivity, particularly in areas of significant visual field loss within the same testing session, which is also known as short-term fluctuation. And because of this factor, a perimetry result should not be discarded because of high false negative response rate. And false negative testing is actually no longer done in the latest generation of algorithms such as the CETA faster algorithm. Long-term fluctuation refers to variation in the threshold sensitivity at a particular test location between two testing sessions, and long-term fluctuation can occur in glaucoma but is more commonly physiological. And it has been seen that on serial testing, test locations which later develop reproducible defects have long-term fluctuation prior to the development of these reproducible defects. Foveal threshold is another parameter which is found below the reliability criteria, and foveal threshold should correspond to visual acuity of the patient. If foveal threshold is high but visual acuity is low, it suggests uncorrected refractive error, but if foveal threshold is low but visual acuity is better, it suggests a very localized foveal lesion. So in this test report, foveal threshold was not measured, and in this test report foveal threshold was found to be 30 decibels. In the Humphrey Visual Field Analyzer, the plots and maps and summary indices are used to detect abnormalities in the visual field. The plots and maps include the numerical threshold sensitivity plot as shown here in this figure, and located here in the test report, and which shows the actual threshold sensitivities at each testing location. So the figures at each testing location in the numerical threshold sensitivity plot are the actual threshold sensitivities of that testing location. And the grayscale map as shown here in this figure shows the threshold sensitivity values closer to 0 decibels as darker areas, and threshold sensitivity values closer to 50 decibels as white areas. The total deviation plots and maps are located in this sector of the test report, and we have a numerical total deviation plot and a probability total deviation map. The numerical total deviation plot shows the numerical difference between the measured threshold sensitivity of the patient and the average threshold sensitivity in age-adjusted normal population at each test location. So if at this test location the total deviation is shown to be minus 33 decibels, it means that the measured threshold sensitivity of the subject at this test location is 33 decibels lower than the threshold sensitivity at this test location of age-adjusted normal population. And the probability total deviation map shows the probability of the measured threshold sensitivity of the patient occurring in age-adjusted normal population. And this probability at every location is represented by a shade, with the probability values for each shade given in the key below the plot. So the shade corresponding to this test location shows that the probability of this threshold sensitivity occurring in an age-adjusted normal population is less than 0.5%. Pattern deviation is given in this sector of the test result, and here also we have a numerical pattern deviation plot and a probability pattern deviation map. To generate the pattern deviation, the machine corrects for any generalized decrease in threshold sensitivity throughout the visual field due to cataract or other media abnormalities, and shows only localized areas of field defects, and this is very important to remember. In this diagram, the green line shows the hill of vision in age-adjusted normal population joining the threshold sensitivities at each point along this meridian, and the red line shows the hill of vision of the patient joining the measured threshold sensitivities at each location along this meridian. And we can see that there is both a generalized reduction in the threshold sensitivity as well as further localized defects along the hill of vision for the subject. But if we measure the total deviation along each point at this meridian, the test locations along this meridian will all show the probability of the total deviation from the normal age-adjusted threshold sensitivity to be very low at each of these points. What the machine does to generate the pattern deviation is to adjust the patient's hill of vision to correct for its generalized depression, so that the threshold sensitivities of the patient's hill of vision is brought nearer to the threshold sensitivities of age-adjusted normal population. As a result, only the areas of localized defects show a significant difference from the age-adjusted normal values. So in the pattern deviation plot, only the test locations corresponding to the localized defects in the patient's hill of vision show a threshold sensitivity significantly different from the threshold sensitivity of an age-adjusted normal population. But the other test locations do not, which had shown a significant difference in the total deviation plot. So the pattern deviation plot is very important to detect localized areas of field defects which are characteristic of early to moderate glaucoma. Pattern deviation represents deeper focal defects within a normal or depressed overall hill of vision which are more relevant to the diagnosis of glaucoma. And the shade used to represent the probability in the probability pattern deviation map represents the probability of the numerical values in the numerical pattern deviation plot occurring in an age-adjusted normal population. And the pattern deviation is said to be the best place to look for early glaucomatous visual field defects when compared to total deviation and grayscale maps. And the numerical probability values for each of these shades remain the same for the probability pattern deviation map and the probability total deviation map. If the defects in the total deviation probability map and the pattern deviation probability map are similar, the eye has only focal defects in its visual field. And if the total deviation probability map shows more defects than the pattern deviation probability map, the eye has focal defects in addition to generalized depression of its visual field. After the plots, we have the global indices or the summary indices located here in this sector of the test report. And among the global indices, we have the glaucoma hemifield test, the visual field index, mean deviation, and pattern standard deviation. The glaucoma hemifield test compares the pattern deviation probability values in 5 predetermined zones of the superior hemifield with corresponding 5 zones of the inferior hemifield. So in the pattern deviation probability plot, it compares 5 zones with its corresponding 5 zones in the other hemifield. But this figure is not given in the test report. And we have to remember that the glaucoma hemifield test is not derived from the grayscale map, although the report of the glaucoma hemifield test is located immediately below the grayscale map. The glaucoma hemifield test can be reported as borderline when the probability of difference between any two corresponding sectors is less than 3% of normal population but not less than 1% of normal population. It is reported as outside normal limits as shown here in this figure when the probability of difference between any two corresponding sectors is less than 1% of normal population. It is reported as generalized reduction in sensitivity if the sensitivity of the best part of the visual field is depressed to an extent expected in less than 0.5% of the population. And it is reported as abnormally high sensitivity if the sensitivity of the best part of the visual field is elevated to an extent expected in less than 0.5% of the normal population. Otherwise, the glaucoma hemifield test is reported as within normal limits, and the glaucoma hemifield test is a very powerful tool to identify glaucomatous visual field defects, and a combination of pattern deviation probability map and glaucoma hemifield test result is said to be highly sensitive and highly specific for detecting early to moderate glaucomatous change. The next index we have is the mean deviation, which is derived from the numerical total deviation plot, and it measures the average of all total deviation values across the visual field. And the value of the mean deviation can vary from positive to negative, with positive values representing visual field better than normal, 0 representing no deviation from the normal, and more negative values representing more severe defects. And along with the value of the mean deviation, a p-value is given which represents the probability of the measured value of the mean deviation occurring in normal age-adjusted population. Pattern standard deviation is also an important index, and it is derived from the numerical total deviation plot. So we note here pattern standard deviation is not derived from the pattern deviation plot. And the pattern standard deviation measures how different the total deviations at each point are from one another. Pattern deviation represents localized defects, and this is important to remember, and pattern deviation is always given as a positive value. Along with the value of the pattern standard deviation, a p-value is also given which represents the probability of the measured value of the pattern standard deviation occurring in a normal age-adjusted population. We note here that the pattern standard deviation value will be large in case of glaucomatous field defects located within a sector of the visual field, but the pattern standard value will decrease when the glaucomatous field defect affects the entire visual field in very advanced glaucoma, and this is important to remember when interpreting the PSD value. Visual field index is another index given in percentage, and it represents the percentage area of the visual field considered as normal. Minimal criteria for diagnosing abnormality is very important to remember, and several criteria have been described. The ocular hypertension treatment study considered a pattern standard deviation with a p-value of less than 5% as indicating a visual field representing early glaucoma. Another criteria is when the glaucoma hemifield test reports outside normal limits. Cluster analysis is another criteria which defines scotoma as three non-peripheral contiguous locations on the pattern deviation probability plot, with each location having a p-value of less than 5% and at least one of these locations having a p-value of less than 1% as indicated by this key. Cluster analysis is represented in this figure, which shows three test locations which are contiguous and non-peripheral on the pattern deviation probability map, with two of the test locations having a probability of less than 2% and one test location having a probability of less than 0.5%, which meets the criteria for a scotoma. Cluster analysis circumvents the inability of global indices for localized loss such as pattern standard deviation to differentiate between scattered and clustered defect locations. Before diagnosing a glaucomatous field defect, the clinician must ascertain that the visual field defect is repeatable, preferably on at least 3 consecutive tests with approximately the same location in the consecutive tests, although the abnormal points may not be exactly the same. The visual field defect should match the optic nerve weight findings, and there is no other pathology of the retina or optic nerve which can explain the visual field defect, and the abnormality is not due to an artifact, and these are very important to remember. Several artifacts can interfere with accurate visual field testing, and we have discussed some of them when we discussed factors affecting the test results. And among the artifacts we have lens rim artifact as shown here in this figure, which can occur when the lens holder is either decentered or is too far away from the eye being tested. Uncorrected diffractive error or miosis can show generalized depression, and eyelid artifact can arise from ptosis, which can lead to loss of superior visual field. Entering incorrect date of birth is also an artifact because that interferes with appropriate statistical analysis. Cloverleaf pattern as shown here in this figure occurs when patient becomes inattentive and stops responding in the middle of the test. Cloverleaf pattern can also be found in malingerates. This pattern is found due to the sequence of presentation of stimuli at various locations, with stimuli being presented nearer to fixation first, followed by at locations farther away from fixation. So cloverleaf pattern occurs because the patient responds to the initial stimuli which are nearer to the fixation, but does not respond later on when the stimuli are presented in the periphery, and we get a cloverleaf pattern. White scotomas are artifacts as shown here in this figure, in which there are locations with abnormally high sensitivity because of very high false positive response from a trigger happy patient who presses the clicker without seeing any stimuli. Visual field defects typical of chronic glaucoma can occur in both chronic open-angle glaucoma as well as chronic angle closure glaucoma, and this is important to remember. Glaucomatous visual field defects result from loss of retinal nerve fiber layer bundles at the optic nerve head, and early glaucomatous visual field defects are characteristically focal. Sequence of damage to the retinal nerve fiber layer in glaucoma is as follows. First, the arcuate fibers are affected, then the papillomacular bundle is affected, and at the very end, the nasal bundles are affected. And loss of a bundle in the superior sector of the retinal nerve fiber layer results in a visual field defect in the corresponding inferior sector of the visual field and vice versa. Similarly, loss of a bundle in the temporal sector of the retinal nerve fiber layer results in a visual field defect in the corresponding nasal sector of the visual field and vice versa. Glaucomatous visual field defects, as shown here in this figure, have certain common characteristics. First and most important, they respect horizontal meridian, and this is very important to remember. This means that the visual field defect does not cross over across the horizontal meridian on the nasal sector of the visual field. So in this figure, these visual field defects respect horizontal meridian in the sense that they do not cross over the horizontal meridian. Also, glaucomatous field defects are almost always localized. In early to moderate glaucoma, they are almost always detectable within the central 30 degrees of the visual field, and they predominantly affect visual field nasal to the blind spot, as we have mentioned. The classic patterns of glaucomatous visual field defects, as shown here in this figure, had been originally described with manual kinetic perimetry, which gives defects with smooth contours, as seen here in this figure. However, in static perimetry, since the test locations are arranged in a grid, the contours of the same defects are not smooth. The most recognizable among the typical glaucomatous visual field defects are the arcuate defects and the nasal step. Arcuate defects occur between 10 and 20 degrees from fixation. Initially, arcuate defects start as focal visual field defects in this region, as seen here and in this figure. We may note here that glaucomatous visual field defects do not respect the vertical meridian and can cross across the vertical meridian. This does not happen with field defects of neurological lesions. And arcuate defects may also appear as an extension from the blind spot, as seen here in this figure, when it is called a sidal scotoma. When fully formed, an arcuate defect, as seen here in this figure, extends from the blind spot, arching over the central 10 degrees to the nasal quadrant up to the horizontal meridian, and a fully formed arcuate scotoma is called a Bjerrum scotoma. We can note here, in the nasal quadrant as compared to the temporal quadrant, the arcuate scotoma is broader, deeper, and nearer to fixation. And when an arcuate scotoma reaches the periphery of the tested field, it is called a breakthrough arcuate scotoma. And in this figure, we see a double arcuate scotoma, one in the superior hemifield and another in the inferior hemifield. It is important to note that when the two arcuate scotomas in a double arcuate scotoma are not continuous, each arcuate scotoma ends at the horizontal meridian in the nasal sector. In this report, we find an arcuate defect both in the total deviation probability plot and the pattern deviation probability plot, and both are similar in appearance, although as we have mentioned previously, the pattern deviation plot is the more important one to consider. In this figure, we see a fully formed arcuate defect extending from the physiological blind spot and involving almost the entire supranasal sector of the visual field apart from the area near central fixation. Nasal step, as seen here in this figure, is the other more easily recognizable glaucomatous visual field defect, and it can be considered as an incomplete arcuate defect in the nasal sector buttressing on the horizontal meridian. And as we have learned, nasal step occurs because the superior and the inferior arcuate fibers are not damaged symmetrically or to the same extent. So there is a relative depression of a vertical hemifield relative to the adjacent portion of the opposite vertical hemifield in the nasal sector. A nasal step can be an isolated defect but can also occur with arcuate defects in one or both of the vertical hemifields. And when nasal sector defects occur in the two adjacent vertical hemifields, the resulting defect can have a central step and a peripheral step, and the peripheral step is called a Ron step. Paracentral scotomas, which occur within 10 degrees of fixation, as seen here in this figure, can also be found in glaucoma patients. Enlargement of blind spot, as seen here in this figure, can also be an early sign of glaucoma. An altitudinal defect is said to occur when an entire vertical hemifield is almost completely affected by a glaucomatous visual field defect, but the other hemifield is spared. Central and temporal islands are found in very advanced glaucoma. when the entire peripheral visual field is lost, and the only remaining portion of intact visual field are in the central fixation area served by the papillomacular bundle and the temporal periphery served by the nasal fibers. The size of these islands progressively diminish in uncontrolled glaucoma. Here in this visual field of very advanced glaucoma, we find part of the central field as well as the extreme temporal periphery is spared. Following this stage in uncontrolled glaucoma, the next to be extinguished is the central island, resulting in loss of central visual acuity, and this loss of central visual acuity can be sudden. The temporal island often persists for a long period after loss of central visual acuity, and this remaining temporal island in this stage can result in eccentric fixation. If glaucoma is still uncontrolled, the temporal island will also eventually be lost, resulting in complete blindness. Rarer visual field defects which can be occasionally found in glaucoma include generalized depression, temporal wedge, and vertical step. We must remember here that vertical step, which respects the vertical meridian, is more characteristic of neuroophthalmic defects. After an attack of acute elevation of intraocular pressure, various field defects can be found which can reverse after the IOP comes back to normal. The severity of glaucoma can also be graded, and in one system, the parameters considered are the mean deviation as well as either the pattern deviation, the pattern standard deviation, or the glaucoma hemifield test. And in this system, the severity of glaucomatous field defect is graded as mild, moderate, advanced, severe, and end stage. And the end stage is defined as worse eye not being able to perform perimetry because of central scotoma, or visual acuity less than 660 because of primary open angle glaucoma. And the better eye can be in any stage of the disease. Even if glaucoma is advanced in only one eye, the disease can be classified as end stage in this system. The structural changes in the optic nerve head should ideally match the functional changes in the visual field. So thinning of the neuroretinal rim in the superior or inferior poles of the optic nerve head should correspond with corresponding defects in the inferior or the superior sectors of the visual field. In early stages, structural changes in the optic nerve head tend to precede functional visual field changes. But in late stages of glaucoma, functional deterioration in visual field can precede detectable structural deterioration in optic nerve head. If there is no correlation between structural and functional changes, another diagnosis should be considered, particularly if degree of cupping does not correlate with the amount of visual field loss, or if pallor is more than cupping, or if visual field changes are not characteristic of glaucoma, or if progression of visual field loss is very rapid. Determining progression of glaucomatous optic neuropathy is another important purpose of visual field testing, and glaucomatous visual field tests worsen by increasing in area and increasing in depth. Increase in depth of a glaucomatous visual field defect implies decrease in sensitivity of that defect, and for determining progression, serial visual field testing is required. Serial visual field testing helps in both differentiating actual scotomas from normal variations and detecting progression. In the initial few visual field tests which a particular patient undergoes, defects can appear because of the patient's learning curve in understanding how to perform the visual field test. And so, often defects noted in the first visual field test disappear in the second test. And in the ocular hypertension treatment study, as many as 86% of the defects found in the first visual field test had disappeared in the second visual field test. This implies that a patient who appears to be glaucomatous in his or her initial visual field report should undergo repeat testing to rule out the possibility that the visual field defects in the initial visual field test are due to patient's learning curve. The other purpose of serial visual field testing is detecting progression in a patient with established glaucoma. And because of normal variations between tests, which is known as long-term fluctuation as we have discussed, detecting progression is difficult. And statistically, progression is defined as a change exceeding expected variability at a particular test location in stable glaucoma patients. We may recall here that the StatPack2 software package has normative data of threshold sensitivities at various locations in stable glaucoma patients. So for identifying progression, patient must be serially tested on the same machine with the same testing algorithm and with the same testing strategy longitudinally over time. And when any new visual field defect is found on follow-up visual field testing, the new defect must be confirmed on 2 subsequent visual field tests before progression is diagnosed, and this is to eliminate the effect of normal variations or long-term fluctuations occurring between the tests. Progression analysis on the Humphrey Visual Field Analyzer can be done by 2 ways: event-based analysis and trend-based analysis. Event-based analysis on the Humphrey Visual Field Analyzer is done with the guided progression analysis or GPA software, and it is based on the pattern deviation plot. Average of 2 baseline tests with reproducible results are considered as the reference baseline, and each subsequent test is compared to the reference baseline. The change of pattern deviation probability at each point is compared with the reference, and the change detected is determined whether to be within expected variability at 95% significance level by comparing the change found in the subject with previous longitudinal change data from stable glaucoma patients available in the machine. And the last test is labeled as possible progression if at least 3 test locations show significant change from the reference baseline in 2 consecutive tests. And the last test is labeled as likely progression if 3 or more test locations show significant change from the reference baseline in 3 consecutive tests. In this report, GPA did not find any significant progression and so has reported no progression detected with each of the successive tests. And the test locations showing changes are indicated with symbols given in this key. Black triangles show worsening points, white triangles show improving points, and dots are used for locations where change could not be analyzed. Prior to GPA software, the glaucoma change probability was available with the full threshold algorithm, and it was based on the total deviation plot and mean deviation and not on the pattern deviation plot. In trend-based analysis, value of a statistical index as recorded in every test is plotted over time. So no comparison with baseline reference is done in trend-based analysis. In trend-based analysis, in addition to detecting progression, the rate of decline is also determined and can be projected into the future, indicating possible visual disability and need for more aggressive therapy. And 2 indices are available. One is the MD index available with the glaucoma change probability software, which is based on total deviation plot and thus takes into account both effects of media opacity and glaucoma to determine progression. And the visual field index finds the percentage of the visual field area considered as normal, and the VFI can range from 100% in an eye which is perimetrically normal to 0% in an eye which is perimetrically blind. Visual field index is based on both the total deviation as well as the pattern deviation plots, and it gives more weightage to central points, and a mean of these weighted scores is given in the printout. So this figure shows a visual field index plot with time recorded in the x-axis and VFI percentage recorded in the y-axis, and this is the time period which has already been recorded, and the slope found in this interval can be projected further into the future. Here it is shown for 3 years, and thus the visual field index 3 years after the last visual field testing done in this patient can be predicted. PSD is not a good indicator of progression because, as we have mentioned, its value increases in early glaucoma with developing focal defects, but the value later decreases when the defects become generalized. Progressor is another software which can be applied on serial measurements taken by the Humphrey Visual Field Analyzer to detect progression. I have kept discussion on the testing algorithms at the very end of this session because it is not very important to know the techniques used by the testing algorithms while we are analyzing the test reports in our routine clinical practice. But still, it is interesting to know the techniques used by these testing algorithms. So you may skip this section without worry. And among the testing algorithms, the suprathreshold algorithm, the full threshold algorithm, and the fastback algorithm on the Humphrey Visual Field Analyzer are no longer used in our routine clinical practice. What we now have and use are SITA standard, SITA fast, and SITA faster. So in suprathreshold testing algorithm, each test location was presented with a stimulus brighter than the threshold of that location in age-matched normal individual, and the subject had to respond whether he or she perceives this suprathreshold stimulus at each test location. So suprathreshold testing algorithm does not test sensitivity at each test location. Although, as we have mentioned, suprathreshold testing algorithm is no longer used in routine glaucoma practice, it can be useful in screening programs, neuro-ophthalmic and retinal conditions, or determining binocular visual disability. In the full threshold testing algorithm, each test location is thresholded with the staircase sequence with 2 reversals. And we have discussed this when we have discussed thresholding. And the pattern used is 422, which implies that during the first crossover, the stimulus intensity is changed by 4 decibels at every step, and during the subsequent 2 reversals, the stimulus intensity is changed by 2 decibels at every step. Testing with the full threshold testing algorithm takes a long time to complete the test in one eye, affecting the accuracy of the test, and so it is no longer preferred. And in the fastback algorithm, thresholding is done by changing the intensity of the stimuli by 3 decibels at every step with only one crossover. This reduces testing time with some loss of accuracy, and again, fastback is no longer preferred. SITA, standing for Swedish Interactive Testing Algorithm, available on the Humphrey Visual Field Analyzer, is currently the most commonly used testing algorithm. In comparison to the previous full threshold algorithm, SITA takes half the time to complete the test in normal individuals, but time taken in advanced glaucoma is almost the same. SITA algorithm is a Bayesian strategy in which probability distribution functions of visual sensitivity at each location is used. For each test location, there are 2 probability distribution functions, one with sensitivity distribution in normal individuals and the other with sensitivity distribution in glaucoma patients. Initially, one test location in each of the 4 quadrants is tested with 25 decibel stimulus, which is considerably higher than the average threshold in normal individuals, and 2 staircase reversals 422 as in full thresholding are performed at each primary location, the primary location being the one test location in each of the 4 quadrants 12.7 degrees from fixation. As the testing proceeds, the PDFs at each location change based on the subject's current response at that location, the subject's previous response at that location, and the subject's response when an adjacent point was stimulated. So we see here in this figure that the 2 PDFs of a test location change their shape with every response to a stimulus at that location and nearby ones. The peak of the PDF represents the most likely threshold at that location, and the width of the PDF represents the accuracy of testing. Testing at a location stops when the accuracy level of thresholding, as represented by the width of the PDF, reaches a predetermined value, provided at least one reversal has been performed at that location. But if the accuracy level is low at a test location, a full threshold with two reversals is performed at that location. And as we have mentioned, a full threshold with two reversals is also performed at the four primary test locations. The mean of the shortened PDF at each location is considered as the threshold sensitivity at that location, and the test location is determined to be normal or abnormal depending on which curve has the highest peak value. And as the test proceeds, the interval between two successive stimulus presentations depend on the speed of the patient's response. And if the patient does not respond after a stimulus presentation, an extra 300 milliseconds is given before the next stimulus is presented. CETA standard became available in the late 90s, and 2 years later, CETA Fast was also made available. CETA Fast takes half the time to complete the test as compared to Fastback, and CETA Fast was shown to be as reliable as CETA standard but takes a shorter time to complete the test. Here again, initially one test location in each of the four quadrants, called the primary test locations, is tested with 25 decibel stimulus, and two staircase reversals are performed at each of these primary locations. But in CETA Fast, these data are used to determine the initial stimulus intensity when thresholding other test locations. And apart from the primary locations, reversals are performed only when the difference between the measured threshold and the normative threshold is large. As with CETA standard, the interval between two successive stimulus presentations depend on the patient's speed of response as the test proceeds. In CETA Fast, as the stimuli intensity are closer to threshold intensity, the stimuli can be difficult for the patient to recognize differentially, and so it is recommended that patients who have difficulty in completing the CETA standard algorithm should not be tested with the CETA Fast algorithm. CETA Faster was available much later, around 5 years back, and it further reduces the testing time, and the testing time required with CETA Faster algorithm is 30% less than with CETA Fast and 50% less than with CETA Standard. In CETA Faster, testing starts at age-adjusted threshold for normal individuals, reducing the number of presentations of the stimulus at each point. Only one reversal is performed at each primary location, and it is important to note that with the CETA Faster algorithm, false negative and fixation loss catch trials are not done. And as with CETA Standard and CETA Fast algorithms, the interval between two successive stimulus presentations depend on the speed of the patient's response. Only 24-2 testing can be done with the CETA Faster algorithm, and CETA Faster seems to give comparable results as CETA Standard, but efficacy for longitudinal monitoring to detect progression has not been established. Average time taken by normal individuals to complete the test in one eye is more than 10 minutes with full threshold algorithm, 7 minutes with CETA Standard, 4 minutes with CETA Fast, and 2 minutes with CETA Faster. With the CETA algorithms, short-term fluctuations and corrected pattern standard deviations which were available with the full threshold program are not reported. GPA and VFI to detect progression are available with the HFA3 model of Humphrey Visual Field Analyzer. Prior to that, the glaucoma change probability program was available to detect progression along with the mean deviation index. And VFI is reported in the printout of all three CETA algorithms in the HFA3 machine. The octopus perimeter from Hackstride is the other common perimeter used, and tendency-oriented perimeter or TOP software is available with the octopus machine. The TOP software tests each location with a single stimulus, and threshold sensitivity at each location is arrived at by comparing with responses from adjacent locations. To recap, characteristic visual field changes of glaucoma include arcuate defects, nasal step, enlargement of blind spot, paracentral scotoma, double arcuate defects, altitudinal defect, and in very advanced glaucoma, residual central and temporal islands. Early glaucomatous field defects respect horizontal meridian. Peripheral visual field is affected first in glaucoma, and the central 5 to 10 degrees of the visual field is affected in advanced glaucoma. Perimetry enables functional assessment of visual field to diagnose and detect progression of glaucoma. Standard automated white-on-white perimetry is the current gold standard in perimetry. Standard automated perimetry allows assessment of threshold sensitivity at predetermined test locations. Standard automated perimeters contain age-bracketed normative data to statistically analyze the probability that threshold sensitivity at each test location is normal or abnormal. On the machine, testing strategy and testing algorithm can be selected according to the clinical scenario. Following diagnosis of glaucoma, at least 3 equally spaced tests should be done per year for 2 years, followed by 2 to 3 tests per year as required. Factors which can affect the test result include refractive error, miosis, media abnormalities, patient's attention level, position of the eye relative to the corrective lens, and duration of the test. When interpreting the test result printout, the following should be noted: identification of the patient, testing conditions such as the stimulus size, background illumination and pupil size, reliability indices, numerical and probability plots, and statistical indices. Reliability indices include fixation loss whose acceptable upper limit is 25%, false positive error whose acceptable upper limit is 15%, and false negative errors, which is actually no longer done in the latest generation of algorithms. Test duration and foveal threshold are also given along with the reliability indices in the test report. Absolute threshold values are given in a numerical plot along with a representative grayscale map. Total deviation maps, numerical and statistical, give the deviation of measured threshold from the normative data at each test location. Pattern deviation maps give the deviation of measured threshold from the normative data after correcting for generalized depression of sensitivity throughout the field, thus showing only localized defects which are characteristic of early to moderate glaucoma. Glaucoma hemifield test compares pairs of zones in the superior and inferior hemifields of the pattern deviation probability map. Since glaucomatous field defects respect horizontal meridian, abnormality in GHT usually represent glaucomatous field defects. Glaucoma hemifield test along with pattern deviation probability map have a high sensitivity and a high specificity for early glaucomatous damage. Mean deviation is an index which represents the average of total deviations of all tested locations. Pattern standard deviation gives the extent by which the total deviation values at the tested points vary from each other. Visual field index represents the percentage of visual field area considered to be normal. Progression of glaucomatous visual field defects on serial visual field testing can be analyzed by event-based analysis such as with the glaucoma progression analysis software, or trend-based analysis such as with visual field index plotting over time. Minimal diagnostic criteria for early glaucomatous defects include pattern standard deviation with a p-value of less than 5%, a glaucoma hemifield test reporting outside normal limits, and cluster analysis with 3 contiguous non-peripheral test locations each have p-value of less than 5% and one of these test locations having a p-value of less than 1%. Before diagnosing a field defect as glaucomatous, we need to ensure that the defect is repeatable with the same approximate location on repetitive testing corresponds to the optic nerve weight findings. in the absence of other retinal, optic nerve, or neuro-ophthalmological lesions, and that the defects are not due to artifacts. It has been a long session, and thank you for listening.